How do you look for a pulmonary embolism? Well, there's a few tests. D-dimer does not look for it. It helps rule it out. The best test we have is a CT angiogram, which is a CT scan with PE protocol, spiral CT. They're all the same thing. It's effectively an angiogram. We also have a VQ scan, which is an old school test but still has its utility. We also have the ultrasound with Doppler, which is useful if you can't do any of the things for the chest and you really think there's a DVT. You find a DVT on an ultrasound, you treat it, heparin to warfarin. If you find a PE, you start heparin. So it's a good test if you can't do any of the others. And then we have the angiogram. We actually put a wire in there. It used to be the gold standard, not anymore. Our CT scans are good enough. The only time you should put a catheter into someone's vein is if you're going to do TPA or going to retrieve some clots. That's usually reserved for people who have chronic thromboembolic pulmonary hypertension or someone who just wants to try it out because the person's already dead. You should not be calling anybody to diagnose PE. You should be doing the CT scan or the VQ. So how do you decide? Wells criteria, yes. Two threes, 4 1.5s, 2 1s. Active malignancies at the bottom, and hemoptysis. The ones in between are going to be surgery within a month, which doesn't count again for immobilization, so immobilization unrelated to surgery. Tachycardia. Any history of DVT. And then the top two, the ones that get a whole lot of points. You have evidence of a DVT. It doesn't mean you have an ultrasound proven DVT, it means you have any of the things we just talked about. And the last one, I'll explain later. ZOMFG, exclamation, exclamation, question mark, exclamation. You think you have a pulmonary embolism. And the reason you think that is because the person has acute, sudden onset dyspnea. They're hypoxemic, or they have pleuritic chest pain. Those are the patients you should be using the Wells criteria in. I have never once seen a pulmonary embolism of import. Asymptomatic, incidental found one, sure. But if a patient comes in complaining of dyspnea or chest pain, and they do not have tachycardia and do not have hypoxemia, they do not have a PE. If they have both no tachycardia and no hypoxemia, they don't have a pulmonary embolism. You shouldn't even consider it. But for everyone else, acute onset dyspnea, pleuritic chest pain, you use the Wells score. How does that help? There's two ways to use it, the old school way and the new school. The old school way is to break it down into less than 2, 2 to 6, or more than 6. And these are three categories that rank into low, medium, and high probability. Low probability, less than 2, high probability, greater than 6, in between, moderate. This was used in perspective of the D-dimer and the VQ scan. The idea was if you have a low probability, you should do a D-dimer to rule it out. I will say that you should not do that. If you have that low of a probability, it's probably not a PE and you should look for something else. Because if you follow strictly the literature, if you have a low probability and the D-dimer is positive, then you should get a CT scan. What happens in the ER is that they get the D-dimer. As a shotgun lab, it's positive, so they get the CT scan. The intention is if you were considering a pulmonary embolism and the D-dimer was positive. But sometimes what happens is the D-dimer gets ordered. D-dimer is elevated for lots of things. If you're that unsure of a DVT, look for something else. If you have a high probability, you should use the VQ scan. The VQ scan requires that you have good lungs. You're going to inject some radiotracer, you're going to see where the blood vessels are. You're going to inhale some radiotracer, you're going to see where your lungs are. If there's a mismatch, that is the blood doesn't go to where the air does, you got a PE. But what actually comes out of this is a tic-tac-toe board. High, medium, low. High, medium, low. What does the test say? What was your pre-test probability? And here's the crazy thing. This is the only one that actually matters. This is the one that can count. If you have a high pretest probability, greater than 6, and the VQ scan says absolutely there's a PE, you got a PE, you can treat it. Or if you said, I doubt there is a PE, there's no way, and the VQ scan says, that's totally normal, then it's useful. Any other combination, throw out the VQ scan. So if they say moderate probability, useless test. So this was pretty complicated, right? And so we said, let's make it easier, new school. And since we have the CT scan to PE protocol, and it is so good, cheap, effective, let's come up with a scoring system for that. In order to do this, you have to have IB contrast, which means you can't do it in someone with AKI or chronic kidney disease. But the new school way of looking at it is the score less than 4? Don't do anything. Is the score greater than or equal to 4? Get a CT scan. This is why that top one is not PE more likely than other diagnosis. It's why it's ZOMFG. I have no idea what I'm doing. I ruled out everything on the dyspnea pyramid. I looked at every single test I have. I know it is nothing else. I don't know what's going on. Please let me get a CT. 3 points. Because if you're considering a PE, you're guaranteed to have one of these things be positive. And if you give haphazardly more likely than other diagnosis, you're just going to get the CT. But that's not how you should use it. That category, the top one, is to ensure you will get the CT scan. So you should only do it if you've ruled out all other diseases. See the approach to dyspnea for the dyspnea pyramid.